I will like to invite our first speaker, Dr.Jit Sarkar, who is again passionate researcher who is mining and doing biomedical data analysis for better clinical outcome, and has been contributing by applying knowledge by doing translational research and finding solutions in multi-omics analysis, as well as learning and applying it for clinical informatics. So over to you, Dr. Jit Sarkar.
Thanks, Mohit. So, am I audible?
Yes, yes.
So, I'll just share my screen. So, is my screen visible?
Yes.
Okay. So, thanks, Mohit, for the opportunity to talk on this topic. As far as we all know, clinical informatics is still in a very immature stage, and considering the deficiency of proper curated structured clinical data, and considering the impact of this particular field, it's still in a developing scenario. So I will just cover some of the use cases and some of the models which we have been developing, and which I have been developing to address various clinical problems. And I'll also brief in these three particular sections. So first, I will talk about the solution categories. So what are the possible categories in which the clinical use cases can be bucketed, followed by a solution life cycle, because clinical data is rapidly generated, and so the clinical models need to be rapidly updated, and so on. And lastly, I will just give a walkthrough of the use cases, of a few use cases from clinical informatics. So starting with my background, so I have done my MBBS almost 6 years back. So by training, I am a clinician, followed by my expertise in data science, and mostly building models for metabolic diseases. So that's how I wanted to combine these two areas to develop these clinical models. So to summarize, we can have we have been working. I have been working on 6 different type of solutions. So starting with the left one. So this is the broad category of predictive analytics. So this is more of a supervised modeling, where there are use cases like days to get hospitalized, length of stay prediction. It's a very important marker for the hospital performance, chronic disease risk prediction, and of course, COVID-19 prediction. So these are all predictive models where we have the data and we can do some predictions. Next comes the cluster identification, where you can identify disease subtypes. We can identify subspecialists. So today, things are going to a sub-specialization model, that we go for retina specialist, we go for strabismus specialist. So this is the domain of the ophthalmologists. So how we can identify these subspecialist doctors within a domain of ophthalmologists? These clusters can also be identified from clinical data. We can also identify disease clusters, whether what are the diseases which tend to co-occur in a certain population group of a population of a certain age. And we can also identify patient clusters. Next, we come to time series analysis. Now, time series is a very important part, given the advent of these variables and Fitbits. So it's massive amount of data generated each and every second. And so because the vital parameters of human body are rapidly fluctuating, so we can predict the blood pressure or respiratory rate, or so using some time series models. So from the perspective of hospitals and healthcare providers, you can also predict footfall prediction. So because there are certain diseases which are acute and seasonal, So there is a trend and seasonal nature of patient coming to the OPDs and clinics. So in order to properly manage the burden of patients and the doctors, so we can also do footfall prediction. And lastly, vitals prediction in ICU, which is a major, because in the intensive care unit there are lots of parameters constantly measured almost every minute or even every hour. So those prediction also comes under the purview of translational analysis. Next, we come to image analysis. So it's a very much emerging field with last decade, where X-rays and CT scans and MRIs and even USG, these all things can be automated to a certain extent. Also, for the pathological images, the tissue sections, this can also be automated to a certain extent. Another important part is the handwritten text analysis. This is very important for healthcare domain because healthcare still has massive amount of data in hard copy format. So digital formats you don't always get in countries like in Asian countries and in multiple countries where there has been not, the healthcare system hasn't yet been almost digitized. There are plenty of handwritten texts and scanned PDFs and all those things, and converting them to digital data and structuring them, cleaning them, then extracting medical entities to get insights. This is a very big domain in clinical informatics. And anything can be a combination of all these 5 categories, and it will be a customized model, and that model can also be developed. So clinical informatics covers this broad range of offerings of healthcare solutions. So how does a solution life cycle look like in clinical informatics? So suppose I work with clients where customers can come with some their data or their requirements. So there will be some introduction meeting for the use cases, and followed by that there will be some identification of possible model solutions for the use cases. Then will come the data exploratory data analysis, which is just to explore the data, how it looks, to provide some basic data insights, and then to propose the models. Now, this portion is the most vital part for, from data EDA to the best model proposal. And here there is a constant iterative process to look for more suitable models which can best solve the clinical question. And lastly, and perhaps the most important part, is the deployment and integration of these models to the clinical workflow, because the clinical workflow is already super burdened, be anywhere in the world. So integration of a new technology, of a new model to the existing clinical workflow, assigning nurses or physicians to use that clinical model for their clinical predictive purpose, or assigning a new person who will do this job on their part. This is a very important part, and that's where it also ensures a repeated iterative process where this usability is again and again tested unless the model is properly fit within the clinical workflow. So now the use cases. So just an overview. I will discuss today about, I just give some examples of supervised models, unsupervised models, graph network models, and some time series models. So we can just build some business insights. We can optimize the cost of expenses of the hospital. An evolving concept is value-based care. Value-based care means where there is every clinical treatment or a clinical intervention can be quantified as something valuable. So the healthcare system is gradually shifting towards value-based care. The insurance companies in the US and other countries, they are also focusing on value-based care. So models can also be used for risk stratification, and then identifying high-risk patients, catering to them more frequently, so that the care is more of value, and that serves the purpose of the insurance companies also. Clinical insights, data labeling, model validation, risk stratification. So these are some use cases. Now, an important part is feature engineering, because in clinical domain you have lots of features and lots of different types of features. So it's a very mixed type of data set. So engineering those features to get proper features which can be fed to the model, and which will be having a high predictive value. Identifying those things and feature engineering is a very important part of clinical informatics. Model selection, translational insights is very important. And so predictive models, clustering models, OCR, where we can just scan and extract handwritten notes, image analysis, some use cases are here. And then finally, the application development, IoT management, wearable integration, and remote monitoring. These are also some possible use cases. So now, doing a deep dive, so I will just walk through the skeleton of a supervised model workflow, just to give an idea of how the thing can be designed. So on the left, you can see the data sources. So we are having electronic health records. We can have wireless wearables, medical devices, clinical notes, pharmacy records, then regular surveys, lab investigations. Now, these data types are of various different structures. So we first of all, you have to structure it, and we have to make it machine readable. So these all deposited to the database. So you also have to connect all these things via a suitable hardware, so that this data is ingested and properly curated on real time. Then comes the data preparation, and from there you can get certain variables. You can get socio-demographic variables. You can get comorbid conditions, lifestyle habits, self-taken surveys, real-time vitals. Now, each category will be having multiple features, and those will be fed to the training data set, will be a validation to develop the model. And now this model can be used to predict, as I already told, length of stay prediction, chronic disease risk prediction, hospital readmission prediction, so predicting post-op complications, vital parameter prediction, and all those things. And the model can be customized and updated as per the clinical need and other things. And we can also do some sort of feature importance scoring, where we can identify that these 3 features or these 4 features are the most important for predicting length of stay. So maybe these 3 features should be the more frequently monitored features for this particular set of patients. So this sort of model can help us predict these sort of clinical outcomes. So for the unsupervised model workflow, I just presented one use case. So suppose we had data of ophthalmologists, and they have been treating particular diseases. Now all the diseases have some standard ICD codes. So if a ophthalmologist treats, suppose a disease code like 6G138. So number of cases of G138 he or she has treated is in a tabular format. Now these all these ophthalmologists will be clustered in an unsupervised manner. And after clustering, when we saw the visualization, what we found is, so there were certain, so these, there was a difference in the clusters. Suppose these blue dots, these were mainly those ophthalmologists who were catering ocular, muscles, and eye movement refraction diseases. This green cluster were those who were providing moldy choroid and retinal diseases. And we found that these green physicians were mainly retina specialists, and these blue one were mainly pediatric ophthalmology and strabismus specialists. So, so you can already identify these subspecialists who are particularly expert in a subdomain of a particular ophthalmological domain. Now, this can be of multiple help. So maybe in this case, so because if so, all of you, I guess, understand a PCA. So a PCA means these blue and these red axis, they are more or less at a 90-degree. So blue people don't contribute to green one. So that means retina specialists don't cater service for pediatric ophthalmology and strabismus, and the also the other way around. So if I can identify a specialist who is having both these skills, then that is a very common, very rare combination, and those persons can be a sort of a common door to these subspecialists. So these sorts of business insights and healthcare insights can also be extracted from these supervised, unsupervised model workflows. So next, I was talking about the graph network models. So suppose in a population, we know that people generally in the geriatric population, they suffer from multiple diseases. So the person has diabetes as well as hypertension, as well as dyslipidemia or hypothyroid in these cases. So if we could identify that at which age group and given a gender, what are the most common co-occurring diseases for that particular group. If we could find that, then given a new person comes, we can just provide a much more personalized screening program. That so you fall in the category of 60 and you are a male, and you are having diabetes. So in that case, you may be having hypothyroid and hypertension and eye disease. So you should be screened for these 3 or 4 diseases. So to achieve this, what we did, we took the disease conditions of all patients, and we calculated the frequencies. So the nodes are the frequencies, and if the 2 nodes are connected, that means these 2 diseases tend to occur more frequently in the population. So suppose one person is diagnosed with long-term current use of aspirin. In that case, there is a good probability of that person suffering from hyperlipidemia, suffering from insomnia, suffering from primary osteoarthritis, suffering from vitamin D deficiency. So this person should be screened for this surrounding 5 diseases. Suppose another person comes with another particular disease. So for that the set of nodes will be different. So this will help us to cater a much more precise and personalized screening, health screening workflow from person to person. So in this case, we just designed it. So just to showcase this thing. So these 7 diseases are closely related to the long-term use of aspirin. So any person coming with this diagnosis should also be screened for these 5 conditions. So there are already some screening protocols in place where one person having over 40 should be diagnosed, should be screened for this condition, but this will make things much more precise and personalized. Lastly, the time series model, which is perhaps the most important, or because it's a very huge data. So here you can see this is the respiratory rate of one person fluctuating with time. So every 2 seconds, the reading has been taken. Now you can see in this particular condition, there is a huge increase of the respiratory rate compared to the other findings. So here there must have some abnormality or some exercise outburst or anything. So if we could predict this hyper value from the preceding values, then we could have prevented or alerted the patient that you might be having an increased respiratory rate in the coming 2 or 3 minutes. So be cautious. So these sorts of things are also right now a bit more hypothetical, and these are being tried by people to model, but this is how the use case looks like. So here we can apply something called change point algorithm. So what it does is it takes the entire stretch and breaks the stretch into certain slices, and For this slice, the mean standard deviation is different from this slice, having a different mean and standard deviation. So we can identify these abnormal slice where the mean and SD is significantly different from the preceding as well as the succeeding areas. And in this case, there's one problem is data has to be real-time synchronized and analyzed. So that is a different problem. It's more of an engineering problem. And in that case, we can also set parameters and rules that if the value is over this certain thing, then give an alert. And we can also build data-driven insights that if the data tells that the person is going to have an increased respiratory rate or heartbeat, then please alert the patient and the surrounding physician, doctor, ambulance, and all those things. So just lastly, coming to the end of my talk, I will just briefly give overview of how end-to-end workflow for chronic disease may look like. So we can just get the data acquisition from the wearables and medical devices. We can do the data prep, feature engineering, model building, clinical decision support, which will be validated with the physicians. And lastly, we can use that thing to produce automated alerts so as to help predict abnormal events, help recognize skipped medicine doses. So if somebody is having a abnormally increasing blood pressure, then we should check that whether the person has skipped his medicine for the last 1 week, or what is the compliance. And that can also be put in as an alert to the person and to the concerned caregiver. For mental health, it's a very important topic coming up, and predicting suicides, predicting depression attacks and panic attacks, manic phase prediction in bipolar disorder. And for this, the data source is much more comprehensive: clinical data, genomic data, vocal expression data, because the vocal expression, how the person is talking over the phone, that changes, and the facial expression changes, social media and regular survey. All these things can be structured and fed into the model, and accordingly we can do prediction. It's definitely very critical. There are certain ethical issues and lots of legal issues, but this is the one direction in which mental health is also going to proceed towards. So I'll just end my talk here, and I'll just take any questions for the last 5 or 7 minutes. Thank you.
Thank you so much, Dr. Jit, for this wonderful talk, where we learned about a lot of application or driven how the industry is looking at the problems and finding solutions. What the students have learned, I guess, is also the same. And I think that we have some questions. So Sonalika, are there any questions from the participants? Or Shri Gauri? I think some Sonalika is putting it in the chat. So let me read it out for you, Dr. Sarkar. So what are the possible career options for people pursuing bioinformatics and clinical informatics?
Okay. So bioinformatics mainly consists of till now genomics, transcriptomics, proteomics, metabolomics, and maybe metagenomics. So a lot of these omics approaches and the data generated from them, this is going to be used for coupled with clinical trial data and with clinical prediction. So the thing is not so mature right now, because as I told, there is a certain lack of bridge between healthcare providers and bioinformatics. But this is where so there are companies who are trying to integrate omics data with clinical trial and clinical outcome data, and those are really big short things which are coming up. So if somebody can have the skill set of bioinformatics and is having the orientation to apply that in clinical care and clinical trial data, that would be a great career in the coming days. Almost a rare skill, I would tell.
All right, that's I think that is helpful. Next, there is a question by Dr. Chitrabratamal. He's asking that graph theory can identify the group of closely related diseases. Can we predict which will come earlier?
Okay, so I guess graph theory. So in graph networks, there are also temporal graph networks. So if we can build temporal graph networks, in that case, we can do predict. But I will tell one thing: the major problem is with data. So suppose a person is having 4 diseases: so hypertension, diabetes, and hypothyroid, and dyslipidemia. So what is the particular chronology of this disease is something very tough to decipher. The person had gone for a clinical visit, got tested with diabetes, and then also found that he is suffering from hypertension. But whether hypertension came before or diabetes, that is a very difficult thing to comment for a real world patient. But this should be something which should also be tried. And given we can have longitudinal data from a certain age where disease doesn't set in and we are having annual checkups, then we can have those data, and temporal graph networks can really identify this sequence of diseases. Yes.
All right. Thank you. Thank you so much for that answer. One last question. Risi M. Vesonga, she is asking, thank you, Doc, for a great presentation. Could you shed some light on your work with metabolic disorders?
Okay, so my work was mainly on type 2 diabetes. So now, as you know, type 2 diabetes is known to be a obesity-driven disease, that people who are obese tend to have diabetes more. But as you may know, that there are certain studies coming up which tell that type 2 diabetes can also occur in so-called non-obese persons. Now, those non-obese persons may have some increased visceral fat, lower muscle mass. That's a different discussion. But why do these non-obese type 2 persons also become diabetic? Because these persons, they contribute to over 50% of the Indian population. So in India, over 50% of type 2 diabetes patients are having a low body mass index, a body mass index less than 25. So my study was mainly to explore the underlying pathophysiology, and I covered, so I studied the adipose tissue of non-obese and obese diabetic persons biologically, and using cell biology, and I studied epidemiological data sets and also clinical records. So that there are multiple levels of the entire thesis, and you can find it on ResearchGate or just by searching me or on Google Scholar citation, and you can just have a good understanding.